Hi, this is Dr. Akhtar Amin and today's topic is keratoplasty or corneal transplantation, also known as corneal grafting. It refers to the replacement of diseased host corneal tissue by a healthy donor cornea. A corneal graft or keratoplasty may be partial thickness. The partial thickness may be interior or posterior lamellar, or it may be keratoplasty may be full thickness. The full thickness is also known as penetrating keratoplasty. This is the brief history of keratoplasty. The first full thickness penetrating keratoplasty was done in 1905 by Edward Conrad Zim for a patient with bilateral alkali burns. A first interior lamellar keratoplasty in 1914 by Anton Ilchnik for interstitial keratitis patient, and first endothelial keratoplasty in 1956 by Charles Stewart for a patient with corneal edema. The general indications of keratoplasty: there are four indications: optical keratoplasty, tectonic grafting, therapeutic corneal transplantation, and cosmetic grafting. The optical keratoplasty is performed to improve vision. Important indications include keratoconus, scarring, corneal dystrophies, pseudopachic bullous keratopathy, and corneal degenerations. The second is tectonic grafting. Tectonic grafting may be carried out to restore or preserve corneal integrity in eyes with severe structural changes, such as thinning with dysmetocele. So this is tectonic grafting. Next is therapeutic corneal transplantation. It facilitates removal of infected corneal tissue in eyes unresponsive to antimicrobial therapy. Next is cosmetic grafting, performed to improve the appearance of the eye, but it is a rare indication. Next is donor tissue. Because in corneal transplant, the replacement of diseased corneal tissue is by donor cornea. So the donor tissue is important and it should be removed within 12 to 24 hours after death of a donor. There is attempt to age match donors in recipients. Corneas from infants, 3 years and under infants, they are used only very occasionally, even for pediatric transplants. Why? Because they are associated with surgical, refractive, and rejection problems. Most corneas are stored in coordinating eye banks prior to transplantation. In eye banks, there are pre-release evaluation, which includes medical history review and donor blood screening to exclude contraindications, and microscopic examination, which include endothelial cell determination, endothelial cell count determination. Corneas are preserved in hypothermic storage. The hypothermic storage is for up to 7 to 10 days, and cornea may be preserved in argon culture medium. The argon culture medium storage is 4 weeks, so it is more than hypothermic storage. 4 weeks and until they are needed. The culture allows extended testing for infective contamination. So the storage media for the donor tissues, they may be short-term storage media, intermediate-term storage media, and long-term storage media. There are two types of short-term storage media: moist chamber and McCary-Kaufman medium. The moist chamber is for 24 hours, while the McCary-Kaufman medium is for 72 hours. Next is intermediate term storage media, which may be Optisol GS, cortisol, U sol C in life 4 degrees C. They are for 10 to 14 days. The long-term storage media, they consist of argon culture medium for 1 month, glycerin for 1 year, and cryopreservative technique for indefinite duration. The contraindications to ocular tissue donation are set out, though there is international variation and the list is not exhaustive. The number one is death from unknown cause is a contraindication. Certain systemic infections such as HIV infection is a contraindication. Viral hepatitis, syphilis is a contraindication. Congenital rubella tuberculosis are contraindications. And septicemia and active malaria. So these are the systemic infections and these are contraindications of donor tissue. The next is prior high risk behavior for HIV and hepatitis, such as sex with someone HIV positive, and men who have sex with men, and intravenous drug abuse, and prostitution. So they are contraindications and they are high risk behavior for HIV and hepatitis. Next is within the last 12 months, if there is sex with someone who has engaged in high risk behavior, who has received blood clotting factor concentrates, who has undergone tattooing, acupuncture, ear or body piercing. So these in the last 12 months, if someone has done this, they are contraindications. Other contraindications are infections and possibly infectious diseases of the central nervous system, such as Creutzfeldt-Jakob disease, systemic sclerosing pain, encephalitis, progressive multifocal leukoencephalopathy, encephalitis, Alzheimer's disease and other dementias, Parkinson disease, multiple sclerosis, and motor neuron disease. Other contraindications are receipt of transplanted organ, patient with most hematological malignancies, patient with ocular disease such as inflammation and disease likely to compromise graft outcome, some malignant ocular tumors, and patient with corneal refractive surgery. The patient with ocular diseases such as retinoblastoma and corneal refractive surgery, and a patient with brain or spine surgery before 1992. Why brain and spine surgery before 1992 is contraindicated? So tell me in comments. The recipient prognostic factors, these should be checked in the recipient, and the host factors which may adversely affect prognosis of a corneal graft and if possible should be optimized prior to surgery. In general, the most favorable cases are keratoconus. The keratoconus followed by localized scars and followed by dystrophies. So severe stromal vascularization, you can see in this picture, absence of corneal sensation, extreme thinning at the proposed host graft junction, and active corneal inflammation. Other prognostic factors are abnormalities of the eyelids such as blepharitis, ectropion, entropion, trichiasis. These should be addressed before surgery. The other prognostic factors are recurrent progressive forms of conjunctival inflammation such as atopic conjunctivitis and ocular cicatricial pemphigoid. Other prognostic factors are tear film dysfunction, anterior synecdoche, uncontrolled glaucoma, and uveitis. So uveitis, uncontrolled glaucoma should be treated, anterior synecdoche, tear film dysfunctions. Starts with types of keratoplasty. The first one is penetrating keratoplasty. So the component layer grafting of the cornea is increasingly utilized, but the full thickness keratoplasty, it remains commonly performed and is the appropriate procedure for diseases involving all layers of the cornea. The key surgical points in the penetrating keratoplasty. A common graft size is 7.5 millimeter. Smaller grafts may lead to high astigmatism, and larger diameters are associated with increased tendency to peripheral anterior synecdoche formation and raised intraocular pressure. So both small and large grafts are there will be problem. The donor button is usually about 0.25 millimeter large in diameter than the host site. So the donor should be larger. Preparation of donor cornea should always precede excision of host tissue, because in a case a problem with the former means that the surgery cannot be completed. Either mechanically guided, manual or automated, including laser trepanation, is commonly used. The graft may be secured with either continuous or interrupted suture technique, or a combination of both. So interrupted, continuous, or both. So these pictures shows continuous sutures, and this picture show interrupted sutures, and these pictures shows excision of the host tissues, partial thickness trepanation, then incision into the anterior chamber, and then completion of the excision. These pictures again shows excision of the host tissues, and then fixation of the donor button. Donor button is placed onto the viscoelastic bed. Initial cardinal sutures are taken, and then interrupted cardinal sutures are taken. So 8 interrupted cardinal sutures are then taken. In the post-operative management is done with topical steroids. Topical steroids are prednisolone acetate 1%, dexamethasone phosphate 0.1%. They are used to decrease the risk of immunological graft rejection. Initial administration is typically every 2 hours with gradual tapering depending on the likelihood of the rejection and clinical progress. Long-term instillation at low intensity, such as once daily for a year or more, is usual. Other immunosuppressants, they are oral azathioprine and topical or systemic topical and systemic cyclosporine. They are usually reserved for high-risk patients. Cycloplegia, for example, homatropine 2% twice daily, is typically used for 1 to 2 weeks. Oral acyclovir may be used in the context of pre-existing herpes simplex keratitis to minimize the risk of recurrence. Monitoring of intraocular pressure. Applanation tonometry is relatively unreliable, so measurement is commonly performed during the early post-operative period with a non-applanation method. Removal of sutures is performed when the graft host junction has healed. This is often after 12 to 18 months. Although in elderly patient it may take much longer. Removal of broken or loose individual sutures should be performed as soon as identified, as this reduces the risk of graft rejection. So broken or loose sutures should be removed, which reduce the risk of vascularization and graft rejection. Post-operative complications, they are divided into early and late. The early complications include persistent epithelial defects, loose or protruding sutures. This picture shows loose continuous suture with probable infection and rejection. There is a risk of infection, marked sterile reaction, and papillary hypertrophy. wound leak, sometimes with flat anterior chamber and iris prolapse, uveitis, elevation of intraocular pressure, traumatic, graft rupture. This picture shows traumatic graft rupture. Cystoid macular edema, microbial keratitis. Here you can see microbial keratitis. Endophthalmitis, you can see in this picture. And rejection, which we will discuss. A rare complication is a fixed dilated pupil called uveitis Zevalia syndrome. Uveitis Zevalia syndrome. The late complications include astigmatism, recurrence of underlying disease, the late wound dehiscence, retrocorneal membrane formation, glaucoma, rejection, which we will discuss, and failure without rejection. So what is corneal graft rejection? Immunological rejection of any layer of the cornea can occur. Rejection of separate layers like endothelial, stromal, epithelial can occur in isolation, but typically a combination is present. Simple graft failure can occur in the absence of rejection, although rejection is a common contributory factor. The risk of corneal graft rejection is increased significantly by the presence of host stromal vascularization. Now, what is pathogenesis of corneal graft rejection? The corneal graft is immunologically privileged with an absence of blood vessels and lymphatics and the presence of relatively few antigen presenting cells. But when there is inflammation and new vascularization, it contributes to loss of this privilege. Important predisposing factors for rejection include eccentric or large graft, over 8 mm in diameter, infection, particularly herpetic, glaucoma, and previous keratoplasty. If the host becomes sensitized to histocompatibility antigens present in the donor cornea, rejection may result. Human leukocyte antigen HLA matching has a small beneficial effect on graft survival. Gender incompatibility has recently emerged as an important risk factor for graft rejection and failure. Whereas the cornea of a female donor can be used in either male or female recipient, the cornea of a male donor should not be allocated to female recipients. What are the symptoms of corneal graft rejection? Blurred vision, redness, photophobia, pain, they are typical. In many cases are asymptomatic until rejection is established. The timing of onset is very variable, occurring from days to years after keratoplasty. The signs vary depending on the type of graft. First sign is ciliary injection associated with anterior uveitis. It is the early manifestation. Epithelial rejection may be accompanied by elevated line of abnormal epithelium. So, in a quiet or mildly inflamed eye, occurring at an average of 3 months. Subepithelial rejection